I'm Dr. Brian Nickel. I've been a practicing anesthesiologist for more than 20 years now, focusing primarily on chronic pain management. I have been advising and managing patients using cannabis for about that length of time. I bring the perspective of a clinician practicing cannabis medicine to this lecture here today. Medical Cannabis Essentials, now it's primarily aimed at caregivers and practitioners looking to learn more about the ancient medication that more and more of their patients are using every day. It's really to serve as an introduction to this. I do hope you find it useful in your treatment of patients and understanding the medications that you're using. And I hope it generates interest in learning more about this very, very safe and often effective ancient medication. We're going to speak today about medical cannabis essentials. Although many clinicians are unfamiliar with cannabis as a medication, with the widespread legalization of medical use across the United States, it becomes important that medical practitioners and caregivers be familiar with the medical use of this drug more and more of their patients are regularly using. Archaeological evidence of human cultivation for cannabis is dated back to 4000 BC in Bampo, Southeast Asia. There it was primarily used as a food source for textiles and fuel. The first medical use of cannabis is documented at 2700 BC, used by the Emperor Shun in China to treat a variety of maladies. It is documented in his textbook, The Herbal, still used as a reference for traditional Chinese medicine. Cannabis use had spread to India by 1000 BC, where it was used religiously, becoming one of the sacred herbs of Hinduism and a sacrament in that religion among the god Shiva followers. With widespread religious use, social use became common, and over time medical benefits were observed and incorporated into the Indian culture. At around 1000 AD, Persian physician Avicenna used cannabis to successfully treat seizures in the son of the king of Persia, and it is mentioned in his textbook Avicenna's Canon of Medicine, which was used as a reference for Western practice well into the late 1800s. By the 1300s, cannabis had traveled to Africa, where it again was used for religious, social, and medical purposes. Cannabis traveled to the New World in the 1500s, but it was not until the 1840s that the actual medical use of cannabis was brought to Western medicine by Irish physician William O'Shaughnessy, who observed the medical benefits of cannabis while stationed in Bombay with the British East India Tea Company. On completion of his contract, he returned to Ireland with seeds of the cannabis indica plant, grew these plants and produced alcohol tinctures from them. After giving them to his dogs and finding that they suffered no ill effects, he began experimenting on his patients and developed many indications for using cannabis extracts in treating a wide variety of maladies. Use of cannabis medications became a regular part of Western medical practice after that. In 1937, the Marijuana Tax Act made cannabis essentially illegal for use in the United States, and the widespread use of cannabis as a medication quickly dissipated. It wasn't until 1964 that the chemical structure of THC was determined, and in 1970, after 1937's Marijuana Tax Act was declared unconstitutional, that cannabis was placed on the newly formed Drug Enforcement Administration's schedule as being one of the most dangerous drugs available for abuse and having no accepted medical use. In 1992, the human endocannabinoid system was identified. California was the first state to legalize medical cannabis use in the United States in 1996. It was in 1998 that the entourage effect, describing how cannabis produced effects in a human being, was described. And by 2021, medical cannabis use was legal in at least 37 states in the Union. Although much of the scientific information about cannabis has evolved quite recently, we human beings have a very long history with this ancient medication. Qualify for medical cannabis use. It is important to note in most states that other conditions which may respond to medical cannabis can be addressed provided the patient has a qualifying condition. One of the reasons so many patients are interested in cannabis and using it has to do with what I call a great virtue of cannabis. And that is that most patients using cannabis will see an improvement in their symptoms. It really doesn't matter what symptoms they're treating or what type of cannabis they use. Up to 90% of people will see some improvement in their symptoms. The endocannabinoid system consists of three core components: endocannabinoids, which are neurotransmitter molecules; endocannabinoid receptors, which the endocannabinoids interact with to produce effects; and enzymes, which break down the endocannabinoids. The endocannabinoid system functions as an inhibitory retrograde signaling system. Endocannabinoids are produced as needed by the postsynaptic nerve cell membrane, which are released into the synaptic cleft, interacting with endocannabinoid receptors on the presynaptic nerve cell membrane, inhibiting further neurotransmitter release. It is essentially ubiquitous throughout the human body, functioning on both excitatory and inhibitory systems. It regulates a wide range of neural and physiologic functions and has a very high prevalence throughout the central nervous system, suggesting that endocannabinoids are fundamental modulators of synaptic function, and they are indeed involved in a wide range of synapse formation and neurogenesis processes. The primary endocannabinoids are anandamide, abbreviated AEA, and 2-arachidonylglycerol, abbreviated 2AG. These are, of course, produced by the human body and are used as neurotransmitters. They are similar in chemical structure to the phytocannabinoids produced by the cannabis plant. Endocannabinoid enzymes break down the endocannabinoids to prevent runaway receptor activation. AEA is metabolized by fatty acid amide hydrolase, abbreviated FAAH, COX-2 lipooxygenase, and by the cytochrome P450 system. 2AG is broken down by MAGL. There are currently two recognized endocannabinoid receptors, the cannabinoid receptor type 1 and cannabinoid receptor type 2. Both types are distributed throughout most tissues of the human body. They do vary with respect to receptor density. CB1Rs are highly present throughout the central nervous system, on peripheral nerves, and reproductive organs. CB2Rs have higher densities on cells of the immune system and throughout the gut, although again they are located in most tissues of the human body. Endocannabinoid receptors are found throughout most tissues of the human body, with one exception, and that would be the brainstem. This is an autoradiograph of specimens stained for cannabinoid receptor 1. The hotter colors indicate increased CB1R density. The cooler ones, lower density levels. We see relatively high CB1R density throughout the brain, except for the brainstem. The brainstem, controlling many autonomic functions, is also the site that many medications demonstrate toxicity. It is a high presence of endorphin receptors throughout the brainstem that account for the respiratory depression and many poisonings seen in patients who abuse opioids. It is the lack of endocannabinoid receptors on the brainstem that account for the safety profile of cannabis and the fact that there has never been a documented overdose death due to use of cannabis. At the most fundamental level, recommending a medication, procedure, or surgery to a patient requires weighing out the risks of the therapy suggested to any potential benefits. Often, it can be a very close call. Other times, the decision can be much more clear. In the case of cannabis as a medication, the very low risks for most patients, weighed against even some potential benefit, makes considering cannabis a safe and potentially effective option to be considered. The endocannabinoid system performs a homeostatic role in the human body, working with and modulating various systems to maintain a stable physiological state. The endocannabinoid system is involved in regulating a great range of processes. It is involved in regulating body temperature, glucose and lipid metabolism, memory, muscle tone, movement, appetite, sleep, moods, inflammation, pain pathways, the immune system. Really, just about everything going on inside the human body On some level, the endocannabinoid system is involved in regulating these processes. When we introduce into a human being a phytocannabinoid, these are the cannabinoids the cannabis plant makes that are similar in chemical structure to the endocannabinoid neurotransmitters produced by the human body. These phytocannabinoids will interact with the endocannabinoid receptors and produce a response. Since the endocannabinoid system is involved in a very wide range of body systems, the administration of phytocannabinoids will affect a wide range of symptoms associated with a wide variety of conditions. And this is the reason cannabis appears to be so effective in treating such a wide variety of conditions. I do view cannabis as being like the old Greek heroes we used to read about a long time ago in high school. Their biggest virtue was always the most tragic flaw that did them in the end. I see cannabis as being no different. The great virtue of cannabis is how easily it helps improve the symptoms of so many different conditions. It really doesn't matter the type of cannabis a patient uses, a gummy bear from the dispensary, a joint they purchase off the street. If they have a neighbor growing a plant next door and they roll it up and smoke it, 9 out of 10 patients will get an improvement in their symptoms. It is a great virtue about cannabis. The tragedy is that's where most patients stop. Taking a gummy bear or smoking a little bit of weed, that helps my symptoms. I'm going to continue to do that. The tragedy is that is where most patients stop. By paying close attention to the cannabis used, routes of administration, and timing, the small improvement most patients experience using any type of cannabis can turn into a tremendous improvement in the quality of their life. Careful selection of cannabis requires knowing the constituents of the plant. Cannabis is composed of more than 400 distinct chemical entities. These can be divided into 3 general categories. Phytocannabinoids. These are cannabinoids produced by the cannabis plant that are similar in chemical structure to the endocannabinoids produced by the human body, and these interact directly or indirectly with the endocannabinoid system. The effects of phytocannabinoids can be modified by other chemicals and cannabinoids present within the plant. Terpenes are a group of chemicals produced by the cannabis plant that do not interact directly with the endocannabinoid receptors, but produce their effects through other mechanisms. They each have their own unique effects and can influence the effects produced by cannabinoids. And the third category I refer to as good humors. Yes, the Greek terminology still work all these millennia later. These are flavonoids, pigments, and other chemicals within the whole plant that may have their own beneficial effects and can interact with the phytocannabinoids and terpenes within the plant to modify these effects. The cannabis plant can produce more than 400 different phytocannabinoids. Most of these are rarely produced and produced in very low concentrations. Some of the more common species of phytocannabinoids you should be familiar with are depicted on the slide. Tetrahydrocannabinolic acid, abbreviated THCA, is the native version of THC produced by the cannabis plant. It is not psychoactive, meaning it does not make you high, but does have some of its own anti-inflammatory properties that could be of clinical use. THCA is converted to the psychoactive version most people are familiar with, delta-9 THC, through a decarboxylation process that occurs through combustion or heating of the cannabis plant. 11-hydroxytetrahydrocannabinol is not actually a phytocannabinoid produced by the cannabis plant, but is a metabolite of delta-9 THC produced during hepatic metabolism. This version of THC is much more potent and longer lasting than delta-9 THC. Cannabinol, CBN, is the end oxidative degradation product of THC. CBN is not psychoactive, meaning it produces no euphoric effects. It does have anti-seizure, anti-cancer, and anti-pain properties. Most patients also find it quite sedating, making it a useful option for treating insomnia. Delta-8 THC varies from the Delta 9 variant in that a double carbon bond moved from the 9th carbon to the 8th carbon. This relatively small molecular change has a big impact on the effects the drug produces. Delta 8 THC is estimated to be only 20 to 50% as euphoric as Delta 9 THC and is estimated to be up to 200 times more potent at relieving nausea symptoms in patients. Tetrahydrocannabivarin, THCV, differs from tetrahydrocannabinol in the fact that the side carbon chain has only 3 carbon atoms rather than 5. This dramatically changes the effects of the molecule, with tetrahydrocannabivarin acting as an antagonist to euphoric effects of Delta 9 THC at low levels. High doses of THCV can produce a very intense euphoric effect that is shorter-lived than Delta 9 THC. THCV also has anti-seizure effects, is an anti-inflammatory in the central nervous system, as are many of the phytocannabinoids, and through interaction with the PPAR gamma receptors, influences gene expression, causing increased production of insulin receptors on peripheral organs, helping to stabilize blood glucose levels in patients with diabetes. THCV, in contrast to THC, is also an appetite suppressant. Cannabidiol, CBD, is one of the most commonly used phytocannabinoids and likely has the broadest spectrum of activities. CBD is anti-inflammatory, has anti-seizure properties, is an antioxidant, has activity on the serotonergic and GABA systems of the brain, making it useful to treat anxiety and depression symptoms in patients, as well as antiviral and antibacterial properties which may give it some general health benefits. It is non-psychoactive and legal throughout the U.S. A prescription version of CBD, Epidiolex, has been shown to be so effective at treating seizure disorders that it has been approved by the FDA for this use. Cannabigerol, CBG, is the first cannabinoid produced by the cannabis plant that is acted upon by additional synthase enzymes to produce the other cannabinoids. CBG has direct activity at the CB2R receptor and is a potent anti-inflammatory agent. Cannabichromene, CBC, is a relatively common cannabinoid in cannabis and also one of the ones that's least studied. Cannabichromene has anti-anxiety properties, anti-inflammatory, and shows some analgesic effects. So the phytocannabinoids all have some of their own unique pharmacological effects, and it is their interaction with the endocannabinoid system and where these receptors are located that determine the effects a cannabinoid will produce. The other main class of chemicals we need to consider in cannabis are called terpenes. Terpenes are aromatic chemicals produced by cannabis. Many other plants and insects also produce terpenes. They are widely recognized on a biochemical level by most life forms on Earth. Terpenes are ubiquitous throughout nature. It was observed by our predecessors in the old tuberculosis days, when all you had to treat patients with was fresh air and sunshine at the sanitarium. The patients who convalesced at sanitariums that were in close proximity to forests, rather than a very arid region, often had better outcomes. They attributed this improvement to the invisible healers of the forest, chemicals that the trees did produce that helped patients with tuberculosis survive the condition. It was in the early 1980s that the Japanese government observed that their citizens who spent time in the forest seemed healthier than those who resided only in cities. They found lower incidences of heart disease, hypertension, and cancer in citizens who spent time in the forest. Subsequent studies showed lower levels of cortisol, a hormone that indicates stress in human beings, lower blood pressures, and higher levels of CD8 cells, referred to as natural killer cells, that fight cancer in people who spent time in the forests. Further research tied this in with the high levels of terpenes produced by plants in the forest that were concentrated under the low forest canopy and the ground. It was inhalation of these forest terpenes that were determined responsible for the health benefits observed. The Japanese government now recommends forest bathing, known as Shinrin-yoku, to all of their citizens for the general health benefits. Spending several hours a week under the forest canopy has been shown to produce significant health benefits in their population, and it has become a generally recommended practice in Japan. There are tens of thousands of terpenes out there in the world, several hundred that may or may not be present in cannabis at any one point in time. Terpenes are produced by the species that produce them for their own advantage. They are produced to protect against ultraviolet light, herbivores, bacterial and viral infections, and to attract pollinating insects. As a result, terpenes have variable antibiotic, antifungal, antiviral, anti-inflammatory, anti-cancer, and antioxidant properties, as well as their own unique effects. Generally speaking, most terpenes are central nervous system depressants. They do exert their effects independent of the endocannabinoid system, although some may have activity at endocannabinoid receptors. Terpenes can interact with phytocannabinoids to produce synergistic effects, and they are, of course, very potent substances. If looking at a laboratory report about cannabis, concentrations of terpenoids above 0.05% are considered of pharmacological interest. We do expect them to have some effect in a human being. In the beginning, classification in cannabis was relatively easy. It was based on the botanical appearance of the cannabis plant. There were two types of cannabis back then. The sativas, they tended to be light green in color, tall, lean plants with long, narrow leaves. Sativa cannabis was noted to give its users some energy, improve focus, and help with depression. Indica cannabis was a much darker appearing plant that was short and squat and had short, wide leaves with dense plant growth. People used indica cannabis, noted to be much more relaxing and sedating than sativas, was better at relieving pain symptoms, improving anxiety, and gave an appetite boost. Of course, human enterprise came into play, and cannabis cultivation became focused on interbreeding the sativas and indicas to achieve different effects. Over the years, this has resulted in myriad strains, each of which produces slightly different to significantly different effects. These strains were all given their own names, many of them entertaining, such as Sour Diesel, Skunk Shocker, and the unfortunately named Green Crack. Over time, these hybrids were bred with other hybrids, resulting in the many hundreds of varieties available today. This really makes the name of the strain relatively useless in anticipating the effects it will produce. Today, with almost every strain available being a hybrid, an alternative classification system has arose. Hybrids tend to be classified based on the percentage of sativa and indica genetics contained within the plant. There are sativa-dominant hybrids, which contain genetically a majority sativa component. We expect sativa-dominant hybrids to have primarily sativa-like effects, that is, to improve focus, give some energy, and help with depression. Indica-dominant hybrids have primarily indica genetics and are expected to produce primarily indica-like effects, improvement of appetite, better at relieving pain, and good at relieving anxiety. The balanced hybrids, having approximately an equal portion of sativa and indica genetics, would be expected to have characteristics of both the sativas and indicas. That is, however, not always the case. There are indica-dominant hybrids that are not at all sedating and relaxing, and there are sativa-dominant hybrids that can give you the dreaded couch lock. Eminent cannabis researcher Dr. Ethan Russo saw the deficiencies in the current classification system, that neither plant morphology nor genetic lineage was adequate in predicting the biochemical content of a strain of cannabis and thus the effects it produces. Rather than thinking of cannabis in terms of the strain or cultivar it is, we should consider cannabis based on the chemovar it is. that is, the actual chemical composition of the cannabis plant in front of us. Only by knowing the actual chemical composition can the effects it produces in a human being be predicted, and only with these assays can optimal symptom improvement be achieved. Predicting the effects a particular chemovar of cannabis will produce brings us to the entourage effect. The entourage effect, in my opinion, is the bedrock of practicing cannabis medicine. The entourage effect was described by Dr. Raphael Mechoulam. He is the Israeli biochemist researcher who determined the chemical structure of THC in 1964 after having determined the chemical structure of CBD in 1963. Dr. Mechoulam states that it is the presence and relative ratio of the phytocannabinoids, terpenes, and other good humors in the whole plant that work together synergistically to produce the effects of cannabis. As not all cannabis contains the same phytocannabinoids, terpenes, and good humors, they tend to produce different effects in human beings. The simultaneous presence of the individual chemicals is required, allowing their interaction together to appreciate the benefits of the entourage effect. Use of the whole plant or extracts of the whole plant are more effective than the isolated natural chemicals. If I were to recommend only one paper regarding the medical use of cannabis to read, it would be Ethan Russo's excellent review article from the 2011 August issue of the British Journal of Pharmacology, entitled Taming THC, Potential Cannabis Synergy and Phytocannabinoid Terpenoid Entourage Effects. It is an outstanding overview of the endocannabinoid system and its modulation by phytocannabinoids and terpenes. It's very well referenced and a great introduction to the entourage effect and effective practice of cannabis medicine. We clinicians all love clinical pearls, the key points gleaned from papers and clinical experience that guide us to effectively treating patients. I'll give you guys my list here. When considering the entourage effect, it is the presence and the relative ratio of cannabinoids and terpenes contained within a specimen of cannabis that determine the clinical effects it will produce. That the combination of THC and CBD is almost always more effective than either alone. That the cannabinoids and terpenes do interact together to produce the clinical effects observed. That using the combination of cannabinoids and terpenes together, it's always more effective than the sum of the individual components. The whole plant or extracts of the whole plant are preferred, likely because we're picking up some of the good humors contained within the cannabis plant. And most importantly, that matching the individual patient, their condition, and symptoms to the most appropriate mix of cannabinoids and terpenes that is necessary to achieve the optimal benefit using cannabis as a medication. Cannabis is available in many different forms. I like to break them up into categories based on routes of administration. The topical method of administration is quite popular, where cannabis extracts are applied to the skin. Advantages of topical administration include a very focused delivery of the medication, the absence of systemic side effects. They work relatively quickly and can be quite effective for skin, muscle, and superficial joint symptoms. Disadvantages of topicals include not being very practical for widespread symptoms. If a patient has generalized arthritis in multiple joints, topical administration can be inconvenient. Topicals do not penetrate very deeply into tissues, again making them effective more for skin and superficial joint symptoms than spine pain or hip pain. Many of the topicals use oils and butters as a solvent, and these can give a greasy residue. Topicals will require repeated administration throughout the day, which can be inconvenient for patients that must remove clothing to apply the medication. The most popular method of cannabis administration is by the inhalation route. The version of cannabis patients will be most familiar with is flower, the actual cannabis plant. Combustion, just smoking the cannabis, is very simple for most patients. The apparatus required to smoke cannabis is very inexpensive. The inhaled route of administration is quite fast-acting, with effects being appreciated within several minutes of inhalation. The quick onset of effect makes dose titration intuitive and easy for most patients to perform. Disadvantages of combustion include, you are creating smoke. The smoke can be irritating to the throat and lungs. The environmental smoke that you create is not very discreet, and combustion is not terribly efficient, with up to 70% of the cannabinoids and terpenes present in the flower lost through the process. Another inhalation route of administration utilizing flower is that of dry herb vaporization. A dry herb vaporizer is an electronic device that contains an oven or chamber in which the cannabis flower is inserted. This chamber is electronically heated to a temperature at which the cannabinoids and terpenes essentially boil off the flower and turn into a vapor or steam, which is inhaled rather than smoke. Advantages to dry herb vaporization include less airway irritation, as only vapor is inhaled. There is no environmental smoke, so dry herb vaporizers tend to be quite a bit more discreet than combustion. Being an inhaled route of administration, dry herb vaporization is quite fast-acting, promoting easy patient dose titration to relieve their symptoms. Dry herb vaporization is much more efficient than combustion, with cannabinoids and terpenes being better preserved, leading to better effects. Disadvantages: there is quite a bit of variability in the quality of the devices available, ranging from some that use an electric wire to essentially combust your cannabis, up through models that cost many hundreds of dollars. These are not quite as intuitive as combustion, in that there is a learning curve associated with using these devices to obtain the best results from them. These are electronic devices, and they will require maintenance and cleaning. A very popular method of inhalation administration is that of using cannabis concentrates in what are referred to as vape cartridges. An extraction process using hydrocarbons is performed on the cannabis flower. The terpenes and cannabinoids collected are in what is referred to as a cannabis oil form. This is a very highly concentrated form of cannabis. The cannabis oil is placed in a glass cartridge, which has an electronic coil activated by a battery that is heated to a temperature at which the cannabis oil turns to vapor, and it is the cannabis oil vapor which is inhaled. Advantages to vape cartridges include only the cannabis oil vapor is inhaled. It can be less irritating to the airways and lungs than combustion methods of inhalation. Vape cartridges are very discreet. No environmental smoke is produced. As an inhaled route of administration, it is quite fast-acting, leading to intuitive dose titration for patients. As cannabis oil vapor is only dispensed when a button is pushed, makes this form of administration very convenient for patients. Disadvantages of vape cartridges are that it can be one of the more expensive ways to use cannabis. Producing the oils and cartridges is not an inexpensive process. Some patients do find the oil vapor irritating to the throat and lungs. Depending on how the cartridge is manufactured, some may lack the terpenes necessary to fully appreciate a good entourage effect. And always advise your patients to only obtain their vape cartridges from legitimate sources that would be legal dispensaries. The so-called vaping crisis of several years ago was eventually found to be a contaminant from clandestine drug laboratories incorporating squalene or vitamin E acetate into their cartridges as a cutting agent. Cartridges obtained from legitimate sources will not contain these adulterants. Cannabis concentrates can also be used in a more raw form compared to that used in vape cartridges. The extract of the cannabis plant usually contains the full complement of cannabinoids and terpenes contained within the plant. These extracts are referred to as being butters, sugars, shatters, or waxes, depending on the physical form and appearance. At this point, I am speaking of using cannabis concentrates with electronic vaporization devices, like the one shown here on the right of the slide. with concentrates, they are heated to a temperature at which they vaporize, turn to a steam, and only the cannabis concentrate vapor is inhaled. Optimal vaporization temperatures for cannabis concentrates are between 315 degrees Fahrenheit and 450 degrees Fahrenheit. This is a temperature range at which the cannabinoids and terpenes will turn to vapor. Patients should always be advised to avoid temperatures higher than 450 degrees Fahrenheit, as the terpenes contained within the concentrate can be converted to carcinogens such as benzene. Advantages to using concentrates by electronic vaporization include the fact that only the concentrate vapor is inhaled. These concentrates tend to preserve all of the strained terpenes. These are highly concentrated forms of cannabinoids, so it can provide quite a high dose for patients with those requirements. Being an inhaled route of administration, it is quite fast acting. Vaporization of concentrates is much more efficient than combustion. The electronic vaporization really allows relatively easy dose titration, as the other inhaled routes do, especially compared to a torch rig that I'm going to describe here shortly. Disadvantages to using concentrates is they can be expensive. Processing the cannabis to produce these is not an easy process. The oil vapor may be irritating to some patients. Having to place small amounts of gooey, sticky concentrate in an electronic vaporization device, that can be inconvenient for many patients. Being an electronic device, there is of course a learning curve associated with this. These devices do require cleaning and maintenance. The electronic devices, though, are much easier to use than a torch rig as far as dose titration, and it is much easier to avoid an inadvertently higher dose than anticipated. Now, I'd just like to touch on torch dab rigs for using concentrates. They are very popular on the recreational cannabis market, and I never recommend them to any of my medical patients for a number of reasons. Torch dab rigs are composed of a titanium nail or quartz cup. This nail, or banger as they're sometimes called, is heated with a butane torch. After the nail or banger is heated, a small amount of concentrate, just a dab, is applied to the nail. This concentrate is instantly vaporized, and the entire dose is consumed in one inhalation. I really never recommend torch dab rigs to any of my medical patients, and I recommend the recreational people do not use these either for a variety of reasons. First off, a butane torch in your living room never sounds like a good idea to me. But more importantly are the temperatures typically used with these torch dab rigs. The titanium nails are typically heated until they have a blood red glow. This corresponds to a temperature in excess of 1,000 degrees Fahrenheit, well in excess of that required to vaporize a concentrate, and well above that at which terpenes may be converted to carcinogens. It is also very difficult to titrate dose with a torch dab rig, as the entire dose of concentrate is instantly vaporized and consumed in one inhalation. It is very easy to overshoot the intended effects. A very effective route of administration for cannabis is the sublingual route using tinctures. Tinctures are liquid extracts, concentrates of plant material, where we pull everything we're interested in out of the plant, concentrated in a liquid, and that is consumed rather than the plant material. There are many advantages to sublingual tinctures. They are very easy to administer. There is no environmental contamination. They are quite convenient for patients to use and very discreet. They are relatively fast acting, with effects setting up between 15 minutes and 45 minutes after administration. This relatively fast acting nature of them makes them relatively simple to titrate to effect. Tinctures administered sublingually do have a longer duration of effect than inhaled routes of administration, which can make them a better choice and more cost effective for long-lived symptoms. Disadvantages to tinctures are few. There is sometimes an unpleasant flavor associated with them. The carrier oil is most often an organic coconut oil, referred to as a medium-chain triglyceride oil, and that does cause abdominal cramping and occasional diarrhea in some patients. And since we're talking about tinctures, I always warn patients that the CBD market is entirely unregulated, and it is imperative to really vet your sources for CBD products before using them. Oral administration of cannabis, the so-called edibles, is becoming a very popular way for patients to use cannabis. Advantages to using edibles include very easy administration. Everybody knows how to eat a gummy bear or a piece of candy. There is no environmental contamination. They're quite convenient and very discreet to use. Edible cannabinoids are potentially more potent and much longer lasting than other routes of administration, which can make them more effective for longer-lived symptoms or for patients that have very high THC requirements. Edibles have significant disadvantages compared to the other routes of administration, however. As anybody who has used an edible will tell you, you never know when they're going to kick in, how hard they're going to hit, or how long they're going to last. So there's quite a bit of variation in onset, intensity, and duration of effects experienced. This makes it quite easy to under or over medicate. These characteristics, of course, make them quite difficult to titrate to effect, and all of this relates to not the edibles, but to the cannabinoids themselves. Cannabinoids are not water soluble. That's why tinctures are always in an oil or perhaps an alcohol form. When using edibles, I always advise patients to consume food that contains fat and high lipid contents to improve absorption of the cannabinoids from the edible. If a patient consumes a 10 milligram Delta 9 THC gummy bear on an empty stomach, much of that THC is going to pass throughout the GI tract unabsorbed, and the patient may experience little to only modest effects from that dose. If the patient consumes that exact same 10 milligram Delta 9 gummy bear while eating a greasy cheeseburger, for instance, the Delta 9 THC is going to combine with the fats and lipids in that meal. Much more will be pulled out of the intestines. After absorption by the gut, the circulatory system takes this blood to the liver for detoxification. In the liver, some of the Delta 9 THC will pass through unchanged to be released into circulation where it does have some of its effects. Much of the Delta 9 THC will be converted into the inactive metabolite of THC called carboxy-THC. This is then released into the circulation where it accumulates in fat tissues for later excretion by the kidneys. Some of the Delta 9 THC will be metabolized to a different form in the liver called 11-hydroxy-THC. 11-hydroxy-THC is much more potent and longer lasting than the Delta 9 variant. The trick is getting it absorbed. Since we're speaking of cannabinoid metabolism, this is a good time to talk about urine drug testing for THC. Urine drug screens look at the presence of carboxy-THC, the inactive metabolite that is excreted in the urine, as evidence of THC use. This inactive metabolite is highly lipophilic and tends to accumulate in fat tissues over a period of time. It can be present in urine anywhere from several days to weeks or a month after last use, so its presence at time of testing does not indicate impairment. In addition, the legal levels of THC present in hemp products, that is less than 0.3% THC, will accumulate as the carboxy-THC metabolite over time. This will show as a positive result for THC in a urine drug screen that is indistinguishable from that of marijuana use. It is a false positive result. The fact that these urine drug screens do not show impairment at time of testing, and the very real fact that there will be many positive results for THC that can occur without marijuana use, mean that the utility of urine drug screening for THC, in my view, is very limited. Fortunately, there are few cannabis and drug interactions that present many issues. Most of the issues arise when the cannabinoids are substrates for enzyme systems through which other medications are metabolized. Interactions I'm particularly concerned by would be HIV patients who are taking protease inhibitors. Depending on the medication, levels may increase or decrease when used with cannabis. I always recommend my HIV patients discuss their cannabis use with their infectious disease physician so that medications can be adjusted if necessary. Patients taking Coumadin, phenytoin, and amiodarone may see increased drug levels and effects when using CBD and/or THC. Typically, these patients are closely monitored and any issues will be detected early in their course. Patients taking Plavix may find the effect of this medication decreased and should be warned of this interaction. Although cannabis has been reported to increase levels of opioids in patients using them, this increase is quite modest and of little clinical significance. A cannabis topic in the news that most of you have probably heard of by now is cannabis hyperemesis syndrome, or CHS. Typically, THC is used to treat nausea and vomiting. However, in some patients, it can have the opposite effect. CHS is a cyclical nausea, vomiting, and abdominal pain syndrome that occurs after using cannabis. It usually occurs in patients who've been using cannabis for a long period of time, predating the onset of the illness. It is typically resistant to treatment with the usual antiemetics and shows this cyclical pattern of hyperemesis occurring every few weeks to several months, at which time the patient is still using cannabis. These symptoms resolve completely after the patient stops using cannabis, and there is the almost universal aspect of the patient's presenting history where they relate that their symptoms are relieved by hot baths or showers. It does look like the incidence of cannabis hyperemesis syndrome is increasing. Now, this could be due to the markedly increased numbers of patients using cannabis as a medication, but I also think it is likely that this condition is overdiagnosed. Nausea is a very common complaint with many patients, and it's tempting to stick a patient with a diagnosis of CHS if they present to you and they're a cannabis patient. It is important to remember there are other things to consider in your differential diagnosis of CHS. Gastritis, reflux disease, peptic ulcer disease, these can all result in symptoms of nausea. Appendicitis, diverticulitis, a sigmoid volvulus, any type of an acute abdomen can also present with nausea as a presenting complaint. Gallbladder disease and pancreatitis can also result in these symptoms, as can kidney stones, UTIs, ectopic pregnancies, and ovarian torsions. These are all conditions that you really should rule out before placing a diagnosis of CHS on a cannabis-using patient. Our gastroenterologist friends at Rome 4 have, of course, come up with a strict criteria for cannabis hyperemesis syndrome. The criteria must be fulfilled for a minimum of 3 months, with symptomatic onset occurring at least 6 months before the diagnosis. CHS presents with the stereotypical episodic vomiting resembling cyclical vomiting syndrome. Presentation is usually after prolonged and typically high-dose cannabis use. Relief of vomiting is achieved by a sustained cessation of cannabis use, and of course CHS is often associated with the pathologic bathing behavior. Complications of CHS include, of course, dehydration that may require intravenous fluids. Patients vomiting are always at an aspiration risk, and prolonged severe vomiting can result in esophageal wall damage. Treatment of cannabis hyperemesis syndrome consists of, hot showers. Your patient's probably already doing that anyway. Although antiemetics are often prescribed, they are usually ineffective. Some practitioners will try tricyclic antidepressants, leveraging the serotonin side of things. Interestingly, topical capsaicin, probably through a TRPV1 receptor mechanism, helps many patients with CHS with these symptoms. And of course, abstinence is the definitive treatment. Cannabis, like any other medication, requires some caution in its use. Strict contraindications to cannabis are few. Patients having active psychosis should avoid THC, as this can exacerbate that symptom. Although rare, patients with actual allergies to cannabis should avoid exposure to it, of course. Patients with very unstable cardiovascular disease should avoid cannabis. There are transient changes in heart rate and blood pressure that occur with cannabis administration that could possibly tip a very fragile patient over the edge to having an adverse event. And of course, pregnant and breastfeeding women should avoid cannabis and probably most other medications. Relative contraindications include patients under 25 years of age. They really should minimize their use of THC, as THC interacts with CB1R receptors that are highly expressed on glial cells in the brain. These cells are intimately involved in brain remodeling that occurs from birth to about 25 years of age, and there is a concern that THC may interfere with this brain remodeling, resulting in developmental delays or psychiatric disorders. Patients with a current or past history of substance abuse disorder are, of course, at increased risk of developing problematic cannabis use. Precautions when it comes to using cannabis? Well, certainly anybody in a safety-sensitive occupation must ensure that they are not impaired at work. Patients using sedating medications may see increased effects from these when using cannabis. Patients with severe liver disease can see levels of medications that are metabolized through the liver enzyme systems rise when using cannabis. Patients with post-traumatic stress disorder or very high anxiety conditions should probably avoid the alpha-pinene terpene, as this exacerbates anxiety in many of these patients. Some heart arrhythmias may be provoked when cannabis containing high concentrations of THC or the terpene linalool are consumed. As far as considerations go, always need to be concerned about older adults. Cannabis can impair spatial awareness and put these patients at increased risk for falls. Of course, patients with concurrent medical conditions, you should always consider how cannabis use will affect these. And many patients are on multiple prescribed medications, and the addition of another drug to their polypharmacy regimen could complicate their care. Other cannabis cautions. Of course, cannabis is medication. Keep it out of the reach of children. As far as cannabis and driving impairment go, THC has been shown to affect response time and motor performance in laboratory studies. However, studies have not shown an increase in motor vehicle accidents due to cannabis use. It has been shown that blood levels of THC do not correlate well with impairment of driving ability, which makes these per se laws, so many nanograms per milliliter of THC and you're considered impaired as you do when alcohol, are really not supported by any scientific evidence. The best response to always give patients is, if you feel different, if you feel high, you really shouldn't be driving at all. Now, as far as legal matters go, disclaimer here, I am not an attorney. This is not legal advice, but these questions come up often with patients. First off, interstate transportation of Delta-9 THC is illegal under federal law. You are not allowed to cross state lines with Delta-9 THC, and you could run afoul of the federal government. I advise all patients that are traveling internationally to be sure to do a very close examination of their luggage to make sure there's not an errant vape cartridge hanging around in the back there somewhere that can propel you from being on a holiday to being a pawn of international intrigue. Use of cannabis in a motor vehicle is prohibited in the state of Arkansas and most states, whether you're driving or not. In the state of Arkansas, cannabis must be stored in child-resistant containers to comply with the law. And Second Amendment concerns come up often. I'm asked very frequently about patients how this works as far as firearms go. I have talked to attorney sources, state and federal law enforcement sources, and the best advice I've heard from all of them is to never be in the simultaneous possession of cannabis and a firearm. I do hope you have found this presentation of some use in your management of medical cannabis patients, or if you're a patient, of some use in managing your own care. I publish patient-oriented medical cannabis information regularly at our website, cannabisexpertmd.com, and on social media accounts using CannabisExpertMD as the handle. We're available on Facebook, Instagram, YouTube, and Twitter. Please like and follow us there so you can keep up with the latest on medical cannabis education, information, news, history, and even some pop culture. In addition to Dr. Russo's paper, suggested textbooks for anybody with a further interest would include Dustin Sulak's excellent Handbook of Cannabis for Clinicians, Principles and Practice. Dr. Sulak goes into very, very high detail in this book for many people to be more of a reference than a easy-to-use text. Kathy Hegel has written A Microscopic View of Medical Cannabis that attempts to kind of thread the needle between the highly technical and research-oriented books such as Dr. Sulak's and the lay press that leaves you thinking, well, just cannabis works for everything. It's well referenced, detailed enough for a clinician, but simple enough for patients to find some use in. This is a point where typically I entertain questions from the audience. As this is a video presentation, I'm not sitting right in front of all you guys right now. If you have any questions, please leave them in the comment section below. My producer Sam will go through them and we'll try to answer them as quickly as possible. In addition, any real good ones we're going to probably use as a frequently asked question that will be answered to the entire community through a video, most likely. Please do remember that medical cannabis is a medication, and don't settle for just some improvement in symptoms that everybody gets using any form of cannabis whatsoever. Learn about this ancient medication. Learn how to use it properly, and that small improvement of symptoms you're achieving or you're seeing in your patients can be transformed into a tremendous improvement in the quality of their lives.